Good afternoon to everyone. So my talk is on Prisms in Strabismus, a handy tool in ophthalmology armamentarium. So we know that prisms have been used everywhere in ophthalmology, and starting from the basic diagnostic test to all the ophthalmic instruments. So, but I would restrict my talk to the use of prisms in strabismus. So a little bit about the basics. So what is a prism? A prism has an apex and a base, and it deviates the light towards its base with the shifting of image towards the apex. So whenever you are placing a prism, the image shift is always towards the apex. A power of the prism, so one prism diopter equals apparent linear displacement of 1 centimeter object away 100 centimeters or 1 meter away. That is one diopter, prism diopter. Coming to the different prism positions, these are the three positions: Prentice, minimum deviation position, and frontal plane position. So Prentice position, as it is showed in the picture, it is perpendicular to your pupillary axis. Minimum and Prentice position generally preferable in the glass prisms. And then we have the minimum deviation position. So why it's called minimum deviation? Because the angle of incidence is equal to the angle of reflection. So here it is. Then the frontal plane position, which is placed parallel to the frontal plane. So a word about Prentice versus frontal position. Any deviation, if we are measured over a Prentice and then measured in a frontal position, it always tends to overestimate in a Prentice position, as you can see in this graph. Then coming to the stacking of prisms, if the amount of measured deviation is above than the available prisms, ideally we should not stack them but split them. Splitting of the prisms reduces, because it will reduce the stacking errors. Although it will little bit underestimate the power. So as I have shown in this picture, if you stack a prism, if you split a prism of 35 and say 20 prisms, the combined value is not 50 but a little more. However, up to 30 prisms over each eye, it's less. And this base, I just want to stress that this only works in the comitant deviations. And we can always stack the vertical and horizontal prisms. Coming to the high refractive errors, so basically plus lenses are what? Plus lenses are with their base together, and minus lenses are with their apex together. So any patient with a plus lenses will always have a measured deviation less than the true deviation, and minus lenses will show a greater than the true deviation. For example, a myopic patient will have overestimation of the esotropia with the minus lenses. So ideally, either we can measure them with contact lens, or we have some normograms in which we can follow this. As you can see, suppose a patient with -7 diopters is measured over 25 or 30 prisms, the actual deviation will be 26 prisms. Similarly, for hypermetropia, because it tends to underestimate, so we can follow the similar normogram. Coming to the oblique prism, so when we are measuring any combined deviations, we have to follow this Pythagoras formula, and the angle is measured. So this is the Pythagoras theorem, and the power is calculated as P, and angle theta is V by P. So generally how we do is we follow this rotation normograph, and the power of excess of the prism, we have to see subjective and objective. So we have to ask the patient, we will rotate the prism and we will ask the patient to tell us when he is able to accept the power and when he is able to see the single. So it is more of a subjective assessment and more than an objective assessment. Coming to the clinical applications of prisms, so it can be diagnostic and therapeutic. So diagnostic uses, we all know, we use it in the form of corneal reflex test, Krimsky, alternate prism cover test in Maddox rod, double Maddox, 4 prism base out, amplitude. I'm not going into the details of these tests. Coming to the therapeutic uses of prisms are in the form of relieving diplopia, restoring binocular vision, and assisting in the fusion exercises. So these are the indications. It can be form of relieving prisms. It can be given in concomitant deviations and in the form of fusion exercises. So in small angle deviations in elderly, we can give the relieving prisms. Then cranial nerve palsy is very important in primary gaze to restore the binocular vision and in aiding in the orthoptic training like in convergence insufficiency. So coming to the types of prisms, it can be a ground-in prisms or Fresnel prisms. So ground-in prisms are prisms incorporated in the glasses. They are limited to up to 6 prism diopters per lens, but they are permanent and they have better optical quality. But they are thicker lenses and little expensive as compared to the Fresnel prisms. Fresnel prisms are flexible, temporary prisms which can be attached to the spectacles, and they are lightweight. But again, they have their cons of they reduce the acuity and contrast. And higher power can be prescribed in a Fresnel prism. So a word about Fresnel prism. Fresnel prism, as I told, it's a thin, negligible weight, and it is cosmetically acceptable even in higher prisms. Made of polyvinyl chloride, consists of a narrow parallel prisms of identical refractive angle arranged in a plastic sheet. So the power of the prism depends on its angle, not on its thickness. So this is a Fresnel prism trial set. So what are the pros and cons? As I told before, it is a lighter, it is cosmetically superior and convenient, and we can push higher prism diopters in a Fresnel prism, unlike a grounded prism. But again, it has its cons, like it reduces the visual acuity and contrast, and it tends to discolor with time. So difficult to clean. So ideally in a prism trial, it should be done in a non-dominant eye and should be done for the primary deviation. This I am telling about the non-incomitant squints, where we have to give it for the primary deviation, the eye with the deviation, and it should be done both for distance and near, and there should be a subjective and objective verification. And as I told before, for oblique prisms, subjective endpoint by rotation of the prism. So a few examples. This gentleman presented with decompensated exotropia after cataract surgery, had double vision and doing well with the Fresnel prism in the left eye. This child actually underwent bilateral LR recession and came with consecutive ET. So for some time she was prescribed prisms, grounded prisms, before planning surgery for the consecutive ET. This gentleman, he had a road traffic accident, and as you can see, he has right oculomotor nerve pulse. You can see he has adduction, elevation and depression limited with the ptosis, and he is doing well with the Fresnel prism. Again, thyroid related ophthalmopathy. These children do very well with the Fresnel prism because they also have intolerable diplopia. Bilateral sixth nerve palsy. This girl doing well with the Fresnel prism. Again, in nystagmus, prisms have a very important role. Why? Because in two ways, they correct the abnormal posture, head posture, and they improve the visual acuity. So in case of improvement of visual acuity, we can give basin prisms so that, you know, they will improve the convergence and improve the visual acuity of the patient. And in case of correction of AHP, as I have shown in the picture, you have to give the prism with the base opposite to the null zone. So suppose a patient has a null point in a way that nystagmus is minimum in right gaze. So we have to give base in the right eye and base out in the left eye till you plan surgery for the patient. Again, in the treatment of hemianopias, the base can be directed towards the blind area so that the blinding area can be pushed and it can provide into the seeing area, and it can provide a larger field of view. And this can be given like that, one side, or it can be given as Pelly prisms. Then aid to the bedridden patient. As we know that bedridden patient, they want to read, they are always in the supine position, so they can be given spectacles through which they can read comfortably. So a base down prism can be given for them. So it's very important that you should explain the patient about the temporary blur, the adaptation time and the potential cosmetic issues. But of course, prisms are very useful because they allow symptomatic relief without any immediate surgery. They are very useful for small angle deviations in acute paralytic squints, any residual deviations after strabismus surgery with a very quick relief of diplopia and asthenopia. Of course, they are very patient friendly and non-invasive. These are my references. Thank you.
Just a doubt. I thought Fresnel prisms were more expensive than ground prisms, isn't it? Fresnel prisms are more expensive. They come about 3,000 to 4,000 rupees, and ground prisms are not as expensive as Fresnel prisms, unless maybe your refractive correction is very high and you may not get it. Fresnel prism, cut it and keep it. Don't throw away the because we use it for hemianopic patients in which you can put the upper segments.
What is your experience on giving oblique prisms? I have seen it in many presentations, but
I have given it to quite a few patients. It
superior
happens,
oblique
like for
paralysis, no?
example, no, like you have a patient with exotropia and thyroid. Thyroid is one common example where you have hypo and ezo. So the dictum is like, for example, you find out which is the largest angle. Suppose ezo is largest and hypo is less. Let's say 20 prisms of ezo and 10 prisms of hypo.
Okay.
Then you start with a something like, middle, like combine larger power than this thing, say 25 or 30 prisms, and you keep it with apex in first, and then slowly start rotating apex down.
Okay.
At one point, patient will say that he can make it single.
You are talking about the Fresnel prisms.
No, yeah, Fresnel prism, correct. Are you talking about ground prisms? No, I have no experience in oblique ground prisms, but there is a nomogram. There's a book in some, especially I think Susan Cotter et al. Their book has a nomogram which tells you the exact angle in which you can, paste the prism. But most of my experience with oblique prisms is with Fresnel.
Yeah, for the ground prism, I think you need to, like, the opticals should know how to make it.
That's
that
another
more than us. So that knowledge is not there among many opticals. But sometimes by just decentering higher, the patient has higher refractive error, you can just decenter the glass to get some. But for the oblique prism, I think Fresnel would be a better option.